thank you very much for talking to us.
Pleasure.
We've got a few questions looking at the new JRCAL guideline. Do you mind talking to us about what's changed in those guidelines?
Yeah, of course. There's a few key changes that have come through in the guidelines. And this is with respect to drownings and submersions, immersions. So the first is that we've formally defined immersion, submersion in the guidelines to avoid any confusion there. Immersion being where somebody is in water, but their airway, mouth and nose is clear of the water, and so that tends to be a wet, potentially cold problem rather than a hypoxic problem, as opposed to submersion where the mouth and nose are below the surface of the fluid, and so then it is a hypoxic problem. Now they may be wet, they may be cold, but generally it's a hypoxic problem. And so that's the whole adage, you can drown in a pothole full of water if your mouth and nose is in it, but being truly submerged means you're under the water. That's the first bit. We've also introduced some discharge on scene for those patients who've had a drowning incident who are well and have supported discharge. And we've also looked at the what was a submersion decision tool used by all the emergency services, fire service, police, coast guard, RNLI, mountain rescue, and tried to make it uniform so that we're working together as a team, so we're not having that juxtaposition on the scene where ambulance wants to do one thing, fire service have a different guideline, and that has subtly changed, which we can go into more detail if you like.
Yes. How important is the patient's body size for decision making?
So when we go to the submersion decision tool, body size is actually quite important. And the reason that is that in some circumstances, survival is greater if you've had colder water and you've lost heat quicker, and therefore you've had a predominantly cooling effect of the brain, and therefore it suffers less from the hypoxic insult that is undergoing. And so you can imagine if you are a larger individual with a lot of adipose tissue, then you lose heat at a slower rate compared to a very small child who have a higher surface area to mass ratio, who is very thin and skinny, essentially. And so if you cool quickly, you use less oxygen in the brain, and therefore it doesn't struggle as much with the hypoxic insult that it's undergoing. This is always difficult though on scene because of course you're asking a very subjective question of those that are around. And generally, if it's a well-set male, adult, they don't cool very quickly. Whereas if it's a very slight child, they will cool very quickly. Now in all of these, when we go through the submersion tool, and I can go through that shortly if you'd like, the key bit is the temperature. The temperature of the water above 6 degrees, we've had no survivors in the literature where the submersion time, so that's mouth and nose below the surface of the fluid, is greater than 30 minutes. Now that 30 minutes starts when we've got the first reliable timestamp on scene, that being attendance of police, ambulance, fire, ourselves or any other emergency service. If the water's colder than that, there are cases of survival. So we have had survivors up to 66 minutes where the water is less than 6 degrees. But that's where there has been rapid cooling, there's been some protection of the brain from that hypoxic insult. And so for those individuals, if it's safe to do so, and being safe is the key word here, we can then extend our search and attempt to rescue in submerged casualties. The challenge, however, is there will be those cases where you're like, ooh, they're 13, so they're a child, but are they big? Are they not big? I don't know. If it's safe to carry on while you gather that information, that's okay. But the key bit is, and one of the things that does come in the submersion tool is the Jessup principles of that has to be a shared decision where as clinicians, particularly in HART, you will be adding into the clinical decision making around that case as senior clinical decision makers. But that's an agreed decision between police, fire and others in attendance at that incident. We're going to go for another 10 minutes because the water's 6.1 degrees, it's safe to do so, and we're not sure how big this individual is. And as we gather further information, because there's stop points, and just like previous tools, there's a stop point at 0 minutes on arrival. Is it safe to perform an attempted rescue and a search in this environment? And that's part of your dynamic risk assessment. And that's around, have we got the safe systems of work in place? Have we got the right personnel to undertake the activity that this requires? Then at your stop points at 30, 60 and 90, At 30 and 60, you're then doing your analytical risk assessment, which is where you've gathered additional information to layer on top of that dynamic risk assessment, and that's around casualty survivability. At that 90-minute point, again, 90 minutes is the point at which we've had no survivors anywhere in the world in the literature of submersion of 90 minutes and greater. And so that will be a point to transition to body recovery. But we have to play this with a little bit of humility. If we know there's a casualty immediately below us, it's a 10-year-old child, for example, and the parents of that child are stood on the side of the bank, we aren't going to stop at 90 minutes. We are, if it's safe to do so, we agree, as Jessup principles, we'll go to 92 because we know where the casualty is, we're just in the point of rescue, bring them to the side, and you can confirm for the family that life is extinct, that this is unequivocally associated with death, and then stop in a way in which doesn't cause that emotional stress that comes with these events, because they are stressful. However, that back to the original principles, that's got to be a coordinated, agreed decision amongst emergency services on scene. Otherwise, this all gets very, very tricky.
Temperature of the water obviously plays a large role in making that decision. Would you consider it appropriate for a esophageal temperature probe to be used to establish that water temperature, or how do you go about establishing whether it's greater or less than 6 degrees?
That's a great question, and the water temperature question comes up frequently. The advice we would put here is always be pragmatic. Don't get stuck on exactly 6, because the esophageal temperature probes will work in bodies of water to give you a temperature. Most of them are rated that low, and most of them will read that, because it's a straightforward thermistor, onto the monitor. However, the body of water you're testing may not necessarily be the body of water in which your casualty is submerged in. And so they always have to be interpreted with caution. And this becomes a game of best guess. On a national level, there is an app being developed where we can actually look at water temperatures, because water temperatures around the UK are very variable. And in a river, for example, if you know the water temperature above the point you're in is 7 degrees and below is 7 degrees, the chances are the bit you're in will be about 7 degrees. If above it's 5.5 and below it's 6.1, the temperature you're operating in may be about 6 degrees. And there is no reliable way of measuring the temperature of where the casualty is until you've found them, which of course brings in that whole problem of do we extend or not extend? Well, our best guess here is it's colder above, slightly warmer below, it's about the region, we have a small thin casualty, it's safe to continue. We agree at our Jessup co-locating coordinated meeting, we'll carry on. There are a few areas, however, where we know consistent temperatures, and one of the challenges we have in the UK is that we have both inland and maritime environments, and then that bit in the middle, and estuarial waters. In a maritime setting, the water temperature never goes below 6 degrees anywhere in the UK, apart from the east coast in February, March. And at that point, it's not that far below. Now, the other challenge with the maritime environment is if you go subsurface, we have to find you first, and there are no survivors in the maritime environment where it's below 6 degrees, and it's probably not a function of the physiology, that's probably a function of if you're subsurface for 30 minutes in a maritime environment, we're just not going to find you, because the sea is quite deep in various places. And so with that, we know for maritime, pretty much nowhere is cold enough, apart from, as I say, February, March. And it's quite seasonal as well, and you can look at various temperature levels, and seatemps.org is a very good website, uses satellite data for sea surface temperatures, and you can see there is a fluctuation. Many people who play in water recreationally will know the sea is warmer towards the end of August, beginning of September into October, cools down through November and December, and it is coldest just before the spring and the sun comes up, March, April time and going forwards, which is why we do have a big risk come end of June, July, when children are going out and playing, and the water temperature might actually be cold enough that they still have cold shock response problems, or are succumbed by the cold quite quickly, because it's still quite cool. There's around between 10 and 14 degrees at that time of year, depending where you are on the coast.
Exposure in cold water is traumatic, even for fit individuals. Steve M. is a diver with the British Army. The water he's being lowered into is 10 degrees Celsius. the temperature of the sea off Britain's coast in June. He's trying to hold his breath. What he will experience is called cold shock.
Sudden immersion in cold water is a very shocking experience. The rapid fall in skin temperature drives breathing. You gasp uncontrollably, and that's followed by uncontrollable hyperventilation, over-breathing. That loss of control of breathing can be very, very dangerous. And what we need to remember is that you only need to inhale a small amount of water to start the drowning process.
Inland water, however, doesn't have those long-term fluctuations. It's very much dependent upon the localised weather and where it's come from. So, for example, if it's snowed in the mountains, that snow will then come down through to the rivers, then those rivers will be cold. If you have a shallow pond, that shallow pond will be very much at the behest of the surrounding environment, whereas a deeper lake, the shallows will be quite cool potentially on that cold day, but the central areas and deeper may be slightly warmer. And so there are temperature fluctuations. And the same with rivers. If it's been heavy rain and cold days in the preceding few days, it'll be cooler than if it's been scorching hot in the previous few days and it's warmed up. And that's where having river temperatures either side, which are available through places like the Environment Agency, but it's not as easy to get hold of. That's where the app's going to come into its own when it's eventually released, because it will be able to give you that live data at the point at which you're trying to make a decision on water temperatures. Generally, summer it's going to be pretty warm unless the proceeding has been very cold, and towards winter it's probably going to be cooler. And when you look at general river temperatures, once you're going from October onwards, you are going into territory where it may be less than 6.
Thank you. Thinking about temperature then for the patient themselves, tympanic temperatures with a wet patient are, I believe, notoriously inaccurate. And yet we have the esophageal temperature, but I'm aware that there is a selective cooling element in a drowning patient. How do we use that information?
You're right about the tympanics. So tympanic thermometers, if you have cold, wet ears, don't tend to work very well because the ear canal has potentially water in it, particularly from submersions, immersions, and it gives you an inaccurately low reading. The question would always be, what are you going to do with that information anyway? How is that going to infect your patient management going forwards? And so if you have a cold, wet patient talking to you, well, the answer is they need warming up. And if they're talking to you, they can usually be warmed up quite nicely with nice bear huggers, back of a nice warm ambulance, dry clothing, all those things. For those, a tympanic will work eventually, and people will say, oh, I've had remarkable rises in temperature from low in 32 to 36.5 degrees centigrade in the space of 10 minutes. Well, no, you've just dried their ears out, and that's now a more accurate temperature reading for them. But it wouldn't affect any prognostication for that individual. It doesn't affect their clinical management, which will be get you warm, get you dry, get you into hospital for a checkup. Conversely, with the esophageal probes, they tend to be reserved for those patients that will tolerate it through an oral insertion, such as those who've undergone anaesthetic, those who are GCS3, who've got intubated, ventilated, or those that are so profoundly hypothermic they may still be spontaneously breathing, but they may tolerate. But they're an awkward population because, again, if they're in that condition, you wouldn't want to be sticking an esophageal probe into a patient who isn't either in cardiac arrest or under anaesthesia, because there is always that risk. They may A, chewing it, may wake up, but there's usually other things that need to be done for that individual first. Are they useful in that population? Absolutely. And the reason for that being esophageal temperature probes, when they're positioned correctly, will sit in the upper third of the esophagus and give a pretty accurate temperature to core. And if you're considering things like extracorporeal membrane oxygenation or cardiac bypass for these individuals, that temperature will be important in risk stratification. It also helps in terms of more accurate delivery of medicines as part of cardiac arrest management, because again, having been pulled out of the water, if your core temperature is 34 degrees but you're wet and in cardiac arrest, that's not going to impact on your regime for medications and drugs to be delivered during that arrest scenario. Conversely, if they were down at 28 degrees, that then changes the duration between medicines, or admission completely if it is getting lower, like we say down to 28. When you go and lower again, that then helps in your prognostication of that individual if they do go for things like bypass, and that's through using the HOPE score, HOPE, where you can enter time of submersion, temperature, and they can do the predictability. And in some areas, you can then escalate through the critical care teams and to local centres whether they would be appropriate for ECMO or bypass as a treatment for that individual. The challenge with these probes, however, is getting them in the first place, keeping them in the right place, and they are very much a later down the line. I'm a simple soul. Air goes in and out, blood goes round and round, and if that's been achieved and other things are being managed, then we can pop in the esophageal probe. It shouldn't be your first line just because they're drowning and they're a bit wet.
Thank you. What's the push for an early tube in these patients?
Yes, in certain conditions, as with all these things. So again, the patient who is conscious, awake, and talking to you requires a little bit of oxygen therapy. They don't need intubation at that point, because that intubation would require an anaesthetic, and it's not indicated. They may recover very well. You can bridge that individual from where they are to hospital if they start to get elements of respiratory compromise, so increasing work of breathing, tachypnea despite oxygen, and that's through using non-invasive ventilation. So bag valve mask, held on 15 litres, and allowing them to breathe through. And if we have PEEP valves available, which are not available in all teams, they can, again, a little bit of positive end expiratory pressure does assist. And there's some good evidence to suggest that non-invasive ventilation can bridge these people for up to 12, 24 hours from their initial insult, but they need to be conscious to do so. If, however, you've got that patient population whereby they now have evidence of respiratory compromise, be that increasing O2 requirements or increased work of breathing with a reduced conscious level, they're the ones that require anaesthetic to facilitate intubation and positive pressure ventilation. So the intubation is merely part of that pathway for the patient. The bit they need is positive pressure ventilation. And that's all connected into how the pathophysiology of drowning works. As you're aware from the base teaching within the paramedicine, a little bit of water washes out the surfactant, and the surfactant is the element that keeps the alveoli splintered open. And without it, it's a bit like trying to blow up a kid's balloon, that element. And so for those patients, they've now got washout of surfactant, they've got alveolar collapse. They may also have water actually in the alveoli, and so it's preventing that interface between the air coming in with the oxygen and the bloodstream where it needs to get to, and so you develop a shunt. And so positive end expiratory pressure and a raised interthoracic pressure through the act of ventilation, positive pressure, actually helps reverse some of that shunt and allows some transmission of oxygen through into the blood cells. Now obviously in the semi-conscious, not GCS3, not cardiac arrest patient, that requires facilitating through anaesthetic, which currently within SWAST is within the critical care team's remit, or basics doctors come in to assist. As I say, the bridge is non-invasive ventilation, so assisted ventilation with bag valve mask. But the risk there is that you actually push more gas through into the stomach. And often in the drowning scenarios, you try to hold your breath when you're underwater, funnily enough, and if you can't hold your breath, you preferentially swallow water rather than inhale it. So quite often in drowning casualties, they have stomachs full of fluid. Now that has a two-pronged problem, or three arguably. The first is that's going to be quite a lot of volume in the stomach, and so they're more likely then to vomit and for fluid to be up in the airway as liquid and vomit at the point of having to do any airway management. The second is that splints the diaphragm. So these are lungs that have already had a little bit of water aspiration, you've got collapsed alveoli that are a bit stiff, collapsed, they're working hard, and it's been splinted from underneath because they've got a stomach full of fluid that's compressing that. The third element to all of that, of course, is if the water's cold enough, that's going to be accelerating their cooling, because some of these patients, adult male for example, will take anything between 2 and 5 litres of water sat in their stomach, and 2 to 5 litres of water at 5 to 6 degrees will cool you really quite quickly. So again, there's a role here potentially for orogastric tubes in that unconscious patient, emphasis on the unconscious so it can be tolerated. And again, if we're using non-invasive ventilation as a strategy to go from A to B where we don't have the option for pre-hospital emergency anaesthesia, an orogastric tube will actually help in draining off that gas, draining off some of that fluid, so prevent any further cooling. We allow some positive pressure ventilation through your bag valve mask ventilation and assisted vents, and will bridge us to a hospital facility where that patient can undergo anaesthetic. In the casualty who's in cardiac arrest, there is a role for intubation. Now, when you go to the evidence, there's insufficient evidence to say that intubation is beneficial or harmful. And when you look at some of the statistics around drowning in the retrospective data space evidence, intubation is always compared to bag valve mask and supraglottic airways in terms of treatment, and comes out with a worse mortality overall. The risk, however, is that most patients who get intubated have been in cardiac arrest for longer than those who've received bag valve mask ventilation or iGels or supraglottic airway devices. And so it's only a sicker population that are receiving intubation, and therefore you would expect their mortality to be higher long term. Reasons to intubate: it secures the airway, because as we've already mentioned, there's a lot of fluid, a lot of vomit coming up in the back of the airways. They do need that positive end expiratory pressure and raised intrathoracic pressure during ventilation, and that's easily achieved through intubation compared to iGels or bag valve mask, again because of the volume of liquid potential in the back of the airway. The downside, however, there's two key downsides. The first is, if you raise the pressure inside the chest, you obstruct the preload to the heart, and so these patients then may need a fluid bolus to offset the fact you've increased the pressure in their chest in the first place. It does increase oxygenation. Now we need the air in and out, blood round and round. We now need the blood round and round bit, and that's actually allowing some fluid to get back into the heart. That may be a fluid bolus, and in cardiac arrest states, it's also some of the vasopressors that you'll be using, adrenaline as an example. Conversely, we have to be able to intubate in the first place and do that safely and successfully. And so if it's not a skill set or a competence that's within the individuals at the time, then it's not an option. That's what's happened generally in paramedic practice across the UK, that intubation as a skill is being reduced, and very, very few paramedics are now actually intubating as part of core practice. The HART teams are subtly different, and as you guys are aware, some have access to video laryngoscopes, extended training, and in some areas we do actually have enhanced skills paramedics who have retained intubation as part of their core set. And again, for those individuals, absolutely, intubation is one of the key things. What if you haven't got it though? Well, we have got case series of iGel use. iGels work significantly better than the first generation laryngeal mask airways in that when placed, the original ones used to float out. iGels don't tend to, but one of the things you do need is you need quite active airway management. So whilst your iGel will go in and you can produce the seal pressures required to ventilate, you do need to actively be managing all that fluid that's coming up through suction. The iGels do have the gastric port. They don't tend to work as well because you often get blocked up with a bit of vomit. So sometimes it does need the iGel out, good suction of all that fluid. If you've not got your orogastric tube in, which obviously is the winner, iGel back in and carry on with your ventilation. The caveat again at this point is when you look into the airway of a drowning casualty, there is a pink frothy foam that comes up. And very similar to left ventricular failure, when we see that flash pulmonary edema, we don't worry about the foam. Foam is good for prognostication, but it's bad in terms of it's a distractor and people want to suction it out. Ignore the foam, suck liquid, ignore foam, iGel in, crack on.
You mentioned iGels.
Yep.
Do you know if it's a myth or not that there is a certain temperature at which point iGels won't become malleable and conform to the supraglottic airway?
So it is a fact that iGels are thermoplastics. Mm-hmm. So they will change shape at different temperatures. For iGels, the temperature for which it has to change is up 100 degrees plus in centigrade, and even down to -2-3 degrees centigrade. They still function, they still hold the same shape, but they don't become stiffer or otherwise. So yes, they are thermoplastics, yes they change, but not in the temperature ranges we see in human beings.
So you'd have to either be frozen, solid or boiling for it to become relevant.
Indeed, in which case it's not going to be used anyway. However, there is, if you come away from the device and actually look at how the device works with respect to the human, when you put the device in, it's relying on the soft tissues in and around the oropharynx to seal around the anatomical seal that's sat with the eye gel. In those patients who've had hypothermic issues or have been subjected to lots of water going in and out of the mouth that's uncooled those soft tissues, the tissues are actually less malleable and they're slightly firmer. And so it takes the eye gel just a little bit longer to seat as those tissues start to kind of move around. This compared to the patient having elective anaesthetics, for example, where they're coming at 36, 37 degrees, where the eye gels sit quite quickly because the tissues sifter and mould around. So you're right about the effect, you're right about the thermoplastics, but the two aren't related.
The new JR Calc guideline is either about to be or have just been published. Can you just talk us through what the key changes are in that document, please?
Certainly. So the JR Calc guidelines for drowning, including the submersion decision tool, are due for release on the 21st of October. So some of the key factors: immersion, submersion, as we've discussed previously. Excuse me. There's other elements around how, for those patients, because drowning appears on a spectrum, those patients at the start of that spectrum who are a little bit wet, a little bit cold, can we safely discharge them from scene, or do all patients have to go to hospital? So there's some additional guidance around those that can be discharged from scene. And the key factors are there, similar to if you're being discharged from hospital. There is no clinical requirement to go in, so there's no increased work of breathing, there's no oxygen requirements. All other observations are normal within your Muse scores or equivalent scoring systems that you're using. That they have somebody to go home with, that they are cautioned that sometimes in drowning you have aspirated a little bit of water and that you may have problems up to 72 hours after the event, and that the person they're going home with is responsible enough to get them back into hospital, access to phone, all those other safety netting elements that come with that. And of course any of those being formally documented on the PCR, that is your actions and these are the safety nets put in place. When you then come through those that then have problems, there's some advice around positive pressure ventilation, assisted ventilations, when to call for help for additional services such as yourselves with HART or the critical care teams to facilitate extended skills with respect to delivery of anaesthesia, non-invasive ventilation and onward transport to hospital or to specialist centres as required. Now, within that are those patients, subsets of populations that require a little bit more intervention, and it may be that an adult with additional needs of some kind where an adult safeguarding referrer is required, and so there's a hint towards that. There's also reference to child safeguarding, so any child who has undergone a drowning event, whether they've survived or not survived, is potentially a safeguarding issue. As a minimum for neglect, that they've ended up in that circumstance and aren't supervised appropriately, but there are drowning is associated with other forms of abuse, be that physical or psychological abuse. And so as per the NICE guidelines, any child who's undergone a drowning event requires a safeguarding referral. And again, it may not come to anything, it may be that we're the first people to have seen that incident and then refer on from there. And as discussed, the other key change is with regard to the submersion decision tool, it's been re-evaluated, it's been rewritten, and there are some subtle changes. The key changes are, this is a Jessup principle decision making, because it won't just be the ambulance service on scene. It might be, but it'd be very rare. So it's a joint decision about how long you're going to continue to search for, with an attempt to rescue and resuscitate. And so it's not a rescue tool and it's not a resuscitation tool, it's both. Because there's no point rescuing somebody if you won't resuscitate. You might as well make it body recovery and reduce the risk to rescuers in undertaking that search and underwater body recovery. It's also not a resuscitation tool, because if you don't rescue somebody, you can't resuscitate them. So it is both, it applies both ways, and it's trying to join up that process so that you have both clinicians and responders actually being able to operate together and to do that effective search and as required resuscitation when the casualty comes to the surface. Some of the key changes in that, as I say, there's mention of dynamic risk assessment, analytical risk assessment, as we've discussed previously. There's mention of senior clinical authorisation. Now, in terms of the document, that document is for use by everybody within the UK Search and Rescue and Emergency Services family. And so senior clinical authorisation is paramedic level and above, and there are cues within the tool to ask those to say, if you don't feel comfortable, call for help early from others within your organisation. So within SWAST, for example, that may be the major trauma and resuscitation advice line. It may be the clinical desk. It may be those with enhanced skills within HART, or it may be team leaders, or even those within HART who've actually done the reading and are happy to make those decisions, where paramedics on the standard ambulances or RVs are not happy to make that decision. With children, there is a caveat that within different ambulance services, the rules around termination and resuscitation attempts for children varies. And so again, if there is concern that this is a child and that you may need some support in that transition from 30 to 60 to 90 minutes in terms of continued search efforts, then that's worth getting that conversation earlier with somebody potentially external to the existing party, where there is some further input from senior clinical people within your organisation to assist in that shared decision making around it is okay to stop search at 30 minutes. And that's one of the key changes. Prior to this revamp of the decision making tool, there were 3 or 4 versions of the same tool being used by different emergency services, and they weren't all consistent. And so part of this new tool and the relaunch is, if a casualty has been brought out after 30 minutes where the water temperature is greater than 6 degrees centigrade and the teams are comfortable, that is a body recovery and that person is dead. Now some will say, well, that doesn't fit in with JLCalc, because JLCalc guidelines previously said we have to continue with drowning casualties up to 60 minutes unless it's icy cold or a child, in which case we go to 90. And that's one of the key changes. That 60 minutes in JLCalc for termination and resuscitation attempts, because the casualty is still under the water, has been pulled back to 30. And so that's then affected. There are then guidelines of when resuscitation can be changed, and that will begin going forwards and will join up across JLCalc, because that was the other issue. There was inconsistent guidance within JLCalc itself. And so that's now very clearly in there that if a casualty is underwater for 30 minutes, the water is greater than 6 degrees centigrade, just like a cardiac arrest following a hanging where they've been 30 minutes without bystander CPR from a hypoxic insult, we can terminate resuscitation attempts or not attempt any further. Now there's obviously a little bit of leeway there. As you mentioned earlier, if we are pulling somebody out onto the side of a riverbank at 31 minutes, surrounded by their family and friends, we can, if it's safe to do so, make best efforts, as long as it's a joint decision amongst the team. We will have a look with the ECG, and if we're still asystolic despite some airway interventions, we will be very quickly terminating the resuscitation attempt. As with anything like this, HART teams are very suited to make those pragmatic decisions, and the new submersion decision tool allows that to say, it's been 29.5 minutes, family are here, let's try, very thin person, may have cooled, okay. Equally, it's also empowering those to stop unnecessary, unsafe or high risk searches underwater for individuals when you're drifting beyond the 30 minutes and it's a warm day with warm water temperatures.
Thank you. So for clarity, the decision-making tool, has that got buy-in from other sort of key stakeholders and other agencies as well?
It certainly does. So the initial request came through some joint operational learning that then came up through NARU as it was then. And we were asked as a group of individuals who work in this area to look at the tool and see if we could find a way in which we could make it consistent across all emergency services and responders dealing with water-based incidents. So the initial section to that was we went back to the evidence, looked at the evidence, has anything changed that should change the tool and determine its timings? It hasn't. And we looked at some more recent evidence that confirmed previous case reports and evidence, and two versions of the tool were developed. Those 2 versions were then trialled at a strategic, tactical and operators level, using many of the people that would have been involved with water rescue in some way, shape or form. This included police, fire, ambulance, the Coast Guard, the RLI, independent lifeboats, surf life saving and lifeguard units, mountain rescue and cave rescue, so that all users that may potentially use it could go, yep, we agree, don't agree. And that was all done through the Behavioural Sciences Unit of a UK government who conducted the study for us. Once that was done, it then was done, like I say, operational, tactical and strategic level to see if it was an understandable, usable tool. The amendments were then incorporated, and that's left us with the tool we have now. At that point, the tool and the surrounding words that support it through the JLCalc guidance, and there will be in the future further guidance, again unified for all services following the tool. That went through the Resuscitation Council, who signed it off as approved, and they can then go forwards. It also then went to NHS England and their specialist services, who again agreed with it, a group of clinicians giving their expert advice. And it's been through the National Ambulance Service Medical Directors Group, NASMED, who again have signed it off across the piece. Once all those sign-offs have been achieved, that's then gone through the JLCalc process and integrated into the new JLCalc guidelines. So at the moment, everybody's said yes. However, science is always changing, and as things evolve and change, we may have to come back and revisit the tool in 2, 3, 4, 5 years. But the current tool is 14 years old, so hopefully it'll be someone else's turn by then.
How relevant is the drowning patient or drowning person, whether they've been in salt water or fresh water, for our care on scene?
So the pathophysiology is subtly different. In fresh water, it still washes out the surfactant, you still have alveolar collapse, but the fresh water will actually get absorbed very quickly because of its hyperosmolar state into the cells, and so again the distance between where the air and the blood interface is gets larger, and so you have that shunt. In salt water, however, it's hypertonic, and so once again it will wash out the surfactant, some alveolar collapse, and whatever's left will actually pull fluid into that alveolar space. Again, the distance between the air and the blood interface is widened, and so again you get a shunt and you get a hypoxic insult. It's also the reason in both cases where supplementary oxygen sometimes is just not enough, because you just need the extra pressure to get it across. Does it make a difference on scene? No. Does it make a difference when you get to hospital? No. Does it alter your mortality or your mobility going forwards? No. And the reason being is that once patients get into hospital, there are so many other things that we do iatrogenic to those individuals that any effect, be it large amounts of salt that have been swallowed during the swallowing into the stomach, the damage to the lungs, it makes very little difference to the actual outcomes because of all the other iatrogenic stuff. The bigger risks are the duration of hypoxia and essentially the dose of hypoxia. So it's the extent and the duration. Those are the biggest indicators, which is why when you look at drowning events generally, the biggest prognosticator of survival is submersion time. So if you're submerged for less than 5 minutes, you have a 90% chance of survival, give or take. Once you go to 10 minutes, it pretty much goes down to 50, and then beyond 15 minutes, the survival times, you're now tapering off down an exponential curve. And if you were to compare this to those survivors around hangings, avalanche, where again it's a hypoxia-related issue, they have the same stepwise function, almost like a logarithmic scale drop-off. So on scene makes no difference. The things that will make a difference: time of oxygen not being delivered, any aspiration. So the next question people often ask me is, what about antibiotics? Should we give them all a dose of Augmentin because they've just come out of a dirty water? Again, generally it doesn't matter. You tend to get less infections from salt water compared to fresh water, but the biggest problem is actually the aspirated stomach contents, the same as all our other cardiac arrests we go to. That tends to be a bigger problem later down the line. So antibiotics aren't indicated in that initial phase due to the fact that the bigger problem will be later down the line, and it's worth saving the antibiotics for them. As anything in medicine, there's always the caveat. There has been occasion where we've pulled children out of slurry pits and we're suctioning slurry out of their lungs. And on that occasion, a high clinical decision was made to give a dose of ceftriaxone through a critical care system of governance, because that's very likely to cause a problem because we still have slurry in a child's lungs that we're ventilating.
Makes sense. Considering hydrostatic squeeze, I've been informed that I need to try and rescue and recover everybody from a body of water in a horizontal position. How much of a risk and how significant is hydrostatic squeeze?
So it is important, and this comes down to phenomena of post-immersion collapse. Hydrostatic squeeze is really important in post-immersion collapse. The phenomena here is that the squeeze on the body of the water itself is causing some vasoconstriction, usually due to cooling, but also the pressure itself, and so there's redistribution of blood within the body. The longer you're there, the colder that water, the more squeeze occurs, and the more redistribution of fluid occurs as well. At that point, if you lift these individuals out vertically from the water, they have a sudden drop in blood pressure which a slightly cooler heart can't cope with. And this was typified particularly in military circumstances when people were being hauled up the sides of large vessels and described as waving from the sea, and then suddenly when they were being winched up 10 foot up the side of a vessel in Arctic waters, they were in cardiac arrest. The Lyme Bay disaster is another good example where a group of children were kayaking with a school group, were waving at the search and rescue aircraft, and a single strop lift out the water, that half a dozen of them or more were in cardiac arrest on the floor of the search and rescue aircraft. So this becomes again a function of time and of the temperature of the water. So in the waters in and around the UK coast, around 12 to 14 degrees, half an hour or more stood in a vertical position, you're likely to have some hydrostatic squeeze and therefore risk of post-immersion collapse and extrication. Those individuals will benefit from a horizontal extrication from the water. But we have to be slightly pragmatic about this. If you are lying face down in water, that is minimal hydrostatic squeeze on that individual, and so they can be extricated quite quickly. So the long distance swimmer who suddenly get a little bit faint and wobbly is unlikely to have a significant hydrostatic squeeze compared to the person sat in a life jacket motionless in the water for an hour plus. And so again, once out of the water they can come out, but that little pop of half a metre, excuse me, 12 inches over the side of an inflatable boat is not a significant drop, and so the importance is rescue from the water rather than delaying time to actually come out horizontal. Now of course if the person that you're pulling out of the water is in cardiac arrest or unconscious, all bets are off because you will lose more time extricating them from the water horizontal than you will doing a snatch and grab at that point, because their requirement is for oxygen resuscitation, not for a prolonged rescue extrication because of an intent to stray horizontal. So there has to be a little bit of pragmatism with this. General guidance, half an hour, vertical, in water of sort of 12 degrees as you cut off for thinking, oh yeah, best come out horizontal here. Take it nice and steady. If patients can self-mobilise out of the water, allow them to do so. So often bringing them to the shore, allowing them to stand first, see how they do. If they feel faint and dizzy, your clinical diagnostics have been made, take them out slightly slower. Or allow them to sit in the water for a period of time and to regain, because they're conscious and they're talking to you. Conversely, at the other end of the extreme, anybody who's peri-arrest, cardiac arrest, unconscious, they just need to be out of the water, and coming over 12 inches of the side of a boat is not going to cause any problems at all. Those of you working with aircraft in the future and search and rescue capability will be trained to use double strap, and you'll often see those, they'll have a strap under the arms and then under the legs as well, and they come up in the classic first aid W position. And again, if you think of the distance there between the heart and the bottom of the pelvis, that's more than about 12 inches. So again, rolling over the side of a sponson is not a problem.
Thank you. The previous guideline, Paddy, had quite a sort of strong emphasis on missed injuries. What's, in your experience, the impact of those injuries once the patient is handed over at hospital?
You're right, there are potential for other injuries occurring during drowning events. And that's one of the key reasons we say always look at the mechanism of the incident. So as an example, if you drive your car into the docks, that's a relatively slow speed. But if your casualty is then coming out with a bruise on their forehead, there may have been a head injury. Going into water in most circumstances, you're very unlikely to incur any injuries unless the mechanism around that water entry suggests so. So examples would be have fallen off the back of the boat, was seen to hit the head off the rock. Well, very evidently there the mechanism is this is somebody who's had a concussion who happens to be in water. On the other side of the coin, it may be they were seen to clutch their chest and complain about pain down the left side of their arm before they collapsed over the side of the boat. The chances are that's a medical event that just happens to have been in water. And just like a car crash or an RTC, people don't crash cars just because they're bad drivers. Other things happen. Seizures, strokes, cardiac arrest due to cardiac conditions, diabetic comas and the like. And so it's always worth looking at the mechanism and saying, how has that person got to where they are? Spinal injuries have always been a concern in drowning literature prior to this, including previous JLCAL guidelines. When you look at the literature with regard to this, in terms of injury, the chance of a spinal cord injury is less than 0.05% of all drowners. However, if I said to you this person has been playing in 6-foot dumping surf and is now semi-conscious, you may think, this very likely could have spinal injury and head injury connotations given the mechanism. And so again, it's part of training clinicians to look at not just, it's wet, it's drowning, what is the mechanism of injury, what has happened, and thereby what other injuries do I have. The bottom line, however, is you have an environmental problem plus or minus injuries, and so extrication, air and out, blood round and round, oxygen therapy. If there are concerns from the mechanism around things like spinal injuries or other traumas, there is no problems at all putting pelvic binders on, spinal precautions, etc., and handing those over. As you would with any other trauma patient, you hand over the mechanism, the injuries that you've found, and in most hospitals in the UK now, they will often go through a CT scanner at some stage if there's any evidence that there is other things going on. The diagnostics in hospital, again, will do the same things. But it's very much an ABC approach to these things and see how you go.
Thank you. Can you talk to me a little bit about management of drowning patients with reference to treating them like a wet head injury?
Absolutely. As you say, one of the challenges in drowning is they've had that hypoxic insult. And as we said, this is a dose of hypoxia, duration as well as intensity. And so that hypoxic insult causes cerebral edema, which is one of the big killers later down the line. And so very much like a head injury, they just happen to be a little bit wet. You go down the Goldilocks phenomena of not too much, not too little, just right. And this would apply particularly for the post-cardiac arrest patients or those that have had emergency anaesthesia in the pre-hospital environment of just the right oxygen. So if they're 100% all the time, you can try and titrate your oxygen back down and keeping it above the 95, just like in your post-cardiac arrest patients. The same with the CO2. Somewhere in the normal range is great. Too high, and you know that you're not ventilating them enough, and that's going to be affecting the brain. Too little, and you'll get vasoconstriction in the brain, reducing perfusion. So again, not too much, not too little, just right. The same with glucose, and there are some associations with hypothermia that as your glucose levels drop, the control of shivering and the control of the body goes down. And so again, those patients who have been profoundly cold will be potentially hypoglycemic, and so management of the glycemic control is important. And then the same with blood pressure as well. Yes, when you're cold, your heart rate will go down and your blood pressure will fall, but again, maintaining some perfusion. And as we've mentioned, if you're positively pressure ventilating the chest, obstructing that preload to the heart, a fluid challenge is sometimes appropriate just to help the fluid up. So 250 of crystalloid normal saline, if that's what you have with you. Some people say then, well, what about hypertonic saline? Hypertonic saline in this group, the evidence is actually very poor. It's case reports only. And so at this stage, I would say avoid. But if you have other suggestions that this is a head injury, so a unilateral pupil dilation, impact to the side of the head, or anything in the mechanism of that incident that suggests this could be a direct head injury trauma, then by all means, hypertonic as per normal guidelines for the enhanced care element. But it comes down to Goldilocks. Not too much, not too little, just right.
If I can pick your mind then on a few of the metrics that you mentioned, our peripheral monitoring of oxygen saturations in what is likely to be a cold and wet patient, how accurate are they?
That's an excellent question. There's actually some studies have looked at this, and as you're aware, pulse oximetry depends on good perfusion, and generally the infrared and the red light can't transmit through the water and then the cold tissues particularly well. And so in those initial stages following a drowning event, all your management going ahead, assume hypoxia, give oxygen, and once you then have reliable readings, either from numbers that are consistently correct with an appropriate waveform, or if you have perfusion index monitoring that actually gives you an appropriate perfusion index, then you can trust it, then you can titrate your oxygen down to the Goldilocks, not too much, not too little. But until then, assume low, give lots.
Thank you. And the glucose monitoring, does the point that we only have capillary bed monitoring impact the readings for whether we are then only drawing what would be assumably a lower reading than the patient's actual core?
Absolutely, and again, it's having that knowledge and interpreting it in the context of the scenario. Because not all casualties are cold when they come out. Some will, in a swimming pool, for example, they tend to be a little bit wet, bit chilly, but actually the glucose will be reflective of. It may not be exactly what it is at the core, but if you're profoundly hypothermic, again, it's having that part of your mind to say, actually this is more hypothermia with respect to my glucose monitoring, and so this will be off. But I also know if it's very, very low, then I need to give some anyway, and if it's very, very, very high, that may be the reason why they're in cardiac arrest, and that's part of my handover to the teams when I get into hospital.
So the impact then of temperature on our capillary blood glucose monitoring is potentially significant for our decision
It is
making.
potentially significant. And just like you would with the cold casualties, or even with the pulse oximetry, if you have probes that go onto earlobes, then again they are close to the core, they tend to warm up a little bit quicker, particularly after the initial treatments. Because bear in mind that your oxygen saturations and your glucometry are very much things that you're going to be doing second line after you've done those very basics of airway management, oxygenation and ventilation, and cardiovascular support. It's almost like a second line therapies at that stage. And so hopefully by that point you'll have some circulation to, say, the ears, and again earlobes work quite well for glucometry, and if you have pulse oximetry that can also be used on the ears as well.
And then the gap between our end tidal monitoring and the patient's actual physiology, does that become greater in drowning patients because of the additional shunting?
So yes and no. So you are going to have a wider shunt, so your alveolar to arterial gradient will be wider for your CO2. CO2 thankfully is quite dissolvable, and so you may have shunt gaps of say 1 to 2 kilopascals, but you're also assuming as well that your monitors are appropriately calibrated, where we know that there is a little bit of drift with these things, and we also know that in the initial stages following respiratory arrest, where you then restart ventilation, your CO2 gradient starts quite high, and as that gradient starts to settle down and shallow out, it gets much easier. Now the only way you're going to know that is with point of care testing, which currently within SWAST I believe is only eligible for certain critical care teams that can come and do so, and so they can add that extra layer of refinement to the ventilatory strategy. But if you're aiming for an end tidal CO2 of say 4 kilopascals, knowing that you are going to have a wider gradient, it's an excellent point, then you need to ventilate a bit harder. If the end tidal CO2 is 5, 6, again, start the ventilation, see how quickly it drops, and then if it's still not dropping, then you can increase the ventilation. That being an increase in the volume of ventilation, or the rate, or both, the composite being your minute ventilation goes up. Always in this bearing in mind, as we said before, in the drowning, post-drowning casualties, their lungs will be stiff and a little bit wet, and that will need slightly higher pressures on the ventilator. These patients then need a fluid bolus to offset that increase in pressure. And the caution being that if you suddenly start to get very high pressures, it's because we've gone through that barrier and they've actually developed pneumothoraces that have gone onto tension.
Does that instance increase with their reduced lung compliance?
The evidence is actually quite poor in this, remarkably enough. In the pre-hospital setting, it's never been properly measured. You would have thought, based on the physiology that we'll discuss, that that is actually the case. It's something to consider, but I wouldn't be actively going in and decompressing every chest that I'm positively pressure ventilating. But if in the physiology that I'm seeing in front of me, I've got increasing pressures on my ventilation for a fixed volume, or I've got reducing volumes if I fix the pressure that I'm ventilating, or I've got an now patient who's becoming profoundly tachycardic and hypotensive where previously they've been stable post rescue from the water, I'm thinking, is this pneumothoraces? Clinical examination, in some cases with enhanced care capability that might involve ultrasound guidance to see if there's pneumothoraces or not, and then action. But like any other intervention surgical wise, we don't really want to be doing that unless we absolutely have to, but at the moment the evidence is out. If however you look at ITU patients, then yes, those who go on to develop respiratory compromise with stiffer lungs, they have a higher proportion of pneumothoraces that then go into tension, but that isn't reflective necessarily of the pre-hospital population.
Thank you very much. So in the guideline, drowning is defined as an impairment of respiration within a liquid medium. Does that infer only water, or can it be other substances as well?
You're spot on. So anything that behaves like a liquid, where the casualty has become immersed or submersed, as we discussed before, will be effectively a drowning event. Now this might be mud or slurry. It could even be as far as, say, in a grain silo, where the casualty has become submerged between a medium which is behaving like a liquid. It has low oxygen levels and will surround them and provide a hydrostatic pressure. So anything that behaves like a liquid will give you a drowning-like event. But back to what we said earlier, you've got to think about the mechanism of the incident and how will other factors impact. So for example, if you drown in a grain silo, we need to hand that over because this patient will need an early bronchoscopy in hospital to fish out any extra grain that has actually gone within the trachea or into the lungs themselves.
Thank you very much. This video is going to be shown on our water training over the next sort of 6 or so weeks. If other people come up with other questions, are you happy if we put those into an email for you to respond, please?
Oh, of course, anytime at all. Just get them to ping them across, and Steve will have my number.
Perfect. Thank you very much.
No, thank you.